In the previous class we had started with pancreas, and in pancreas we had discussed about some of the congenital anomalies related to pancreas, like pancreatic divisum, annular pancreas, and after that we had started with acute pancreatitis. And then we had studied about the pathophysiology, then clinical features. After that we had discussed about diagnosis and then management of acute pancreatitis. Along with that, we had discussed how we grade acute pancreatitis, if it is like mild or severe, ಇದನ್ನು ಹೆಂಗೆ ಗ್ರೇಡ್ ಮಾಡ್ತೀವಿ ಅಂತ ನೋಡಿದ್ವಿ. ಆಫ್ಟರ್ ದಟ್ ವಿ ಹ್ಯಾಡ್ ಡಿಸ್ಕಸ್ ಸಮ್ ಸರ್ಜಿಕಲ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಆಲ್ಸೋ. ನೆಕ್ಸ್ಟ್ ಸಿಸ್ಟೋ ಜೆಜಿನೋಸ್ಟಮಿ ಅಂದ್ರೆ ಏನು, ಸಿಸ್ಟೋ ಗ್ಯಾಸ್ಟ್ರೋಸ್ಟಮಿ ಅಂದ್ರೆ ಏನು, ಸಿಸ್ಟೋ ಡುವೋಡೆನೋಸ್ಟಮಿ ಅಂದ್ರೆ ಏನು, ಇದೆಲ್ಲ ಡಿಸ್ಕಸ್ ಮಾಡಿದ್ವಿ. Okay, after that I had stopped near chronic pancreatitis. So from today we'll start with chronic pancreatitis. Just like the name suggests, it is chronic in nature. Okay, chronic andre over a long period of time this disease will manifest, and then it will be presenting in the patient. So it is characterized by irreversible fibrosis of parenchyma, pancreatic parenchyma, with ongoing inflammation. Basically, itis andre I have told you, it is inflammation. If it is cholangitis, it is inflammation of bile duct. If it is pancreatitis, it is inflammation of pancreas. So in chronic pancreatitis, whatever the digestive enzymes of pancreas are there, that will lead to autodigestion, and because of this there will be continuous ongoing inflammation. If this goes on for more than 1 week or 2 week, or it goes on prolonging, then what will happen, there will be fibrosis of this part of the pancreas. Fibrosis basically means it is a complication of inflammation ಆಗುತ್ತೆ, ಅದಾದಮೇಲೆ ರಿವರ್ಸ್ ಆಗಕ್ಕೆ ಟ್ರೈ ಮಾಡುತ್ತೆ. ಬಟ್ ರಿವರ್ಸ್ ಆಗೋಕ್ಕೂ ಟ್ರೈ ಮಾಡೋಕ್ಕೆ if it is not possible to get to reverse it, then what will happen, this tissue will be replaced by some fibrous tissue which is of no functional significance. Okay, na? So basically there will be irreversible fibrosis. Once gone is gone, it is not reversible. So this is chronic pancreatitis. So what are the what all can we see in this irreversible fibrosis? There can be exocrine insufficiency. Exocrine andre duct, endocrine andre related to hormones. So exocrine insufficiency andre it precedes the endocrine. First exocrine insufficiency ಆಗುತ್ತೆ ಯೂಶಲಿ. ಆಯ್ತಾ, ಇದರಲ್ಲಿ ಏನಾಗುತ್ತೆ, 90% of the acini ಅಂದರೆ basically the cells which are lining this duct. These are called duct acini. So these cells which are lining the duct, more than 90% of these will get permanently destroyed. And what does this lead? This leads to indigestion, because these pancreatic enzymes will reach intestine, and this will help in release of certain enzymes like cholecystokinin from gallbladder, and other than that trypsin, chymotrypsin, ಇದೆಲ್ಲ ಫಿಸಿಯಾಲಜಿ ಫಸ್ಟ್ ಇಯರಲ್ಲಿ ಓದಿರ್ತೀವಿ. ಈ ಎಲ್ಲ ಎಂಜೈಮ್ಸ್ ರಿಲೀಸ್ ಆಗಬೇಕು ಅಂದರೆ there should be a factor, this pancreatic juice should reach the intestine to promote digestion. So if there is block or if there is damage to these acini cell, then there will be no proper digestion, that leads to indigestion. There will be no proper absorption, that leads to malabsorption. And whatever this just like I said, this cholecystokinin is present in pancreatic juice. When this this is in the gallbladder, but when this pancreatic juice reaches the intestine, then the signal will reach the gallbladder that digestion of fat is taking place. You release bile. So this cholecystokinin will help in contraction of the gallbladder, leading to secretion of the bile, which in turn will lead to digestion of the fat. If these pancreatic enzymes are not there, cholecystokinin will not be released. If this is not released, then whatever the fat we have consumed, that will go into, as usual, into the feces. So that is called as steatorrhea. If there is more than 7 grams of feces per day, it is called as steatorrhea. ಆಯಿತಾ, ಬೇಸಿಕಲಿ ಇಂಡೈಜೆಷನ್ ಆಗ್ತಿದೆ, ಮಾಲ್ಅಬ್ಸಾರ್ಪ್ಷನ್ ಆಗ್ತಿದೆ, ಅದ್ರ ಜೊತೆಗೆ ಸ್ಟಿಯಾಟೋರಿಯಾ ಆಗ್ತಿದೆ. This is because of exocrine insufficiency. Endocrine insufficiency ಆದರೆ ಏನಾಗುತ್ತೆ, more than 90% of the islet cells are destroyed. These islet cells are the ones which release insulin and hence help in absorption of glucose. If there is destruction of these islet cells, insulin will be reduced. Insulin ಕಮ್ಮಿ ಆದರೆ that is diabetes mellitus. Glucose will be more, or hampered absorption of glucose will be taking place. That itself is called as diabetes mellitus. So the patient may present with diabetes mellitus to you, but it can be a case of chronic pancreatitis. So if you diagnose diabetes mellitus, you should look for these signs also in order to rule out chronic pancreatitis. ಹೊಸದಾಗಿ ಶುಗರ್ ಬಂದಿದೆ ಇವನಿಗೆ, ಓಕೆ ದಿಸ್ ಇಸ್ ಡಯಾಬಿಟಿಸ್ ಮೆಲಿಟಸ್ ಅಷ್ಟೇ, ಇವನಿಗೆ ಆ್ಯಂಟಿ ಓರಲ್ ಹೈಪೋಗ್ಲೈಸಿಮಿಕ್ ಡ್ರಗ್ಸ್ ಹಾಕಿ ಕಳಿಸಿದ್ರೆ ಸಾಕು ಅಂತ ಅಂದ್ಕೊಂಡ್ರೆ ಇಟ್ ಇಸ್ ರಾಂಗ್. If he is a chronic alcoholic, or if he has any risk factors like gallstone, or other risk factors, then we need to evaluate for chronic pancreatitis in order to rule out it. Okay na? Other than that, there will be chronic pain, continuous pain irutte. These are the usually clinical features. Aita? So what are the causes for chronic pancreatitis? For acute pancreatitis, most common cause is gallstones. After that, it is alcohol. But for chronic pancreatitis, it is heavy alcohol consumption, and if he smokes along with alcohol, then it has a synergistic effect. Andre effect double ಆಗುತ್ತೆ. Okay na? Okay, after this, we classify, or we have a classification called Tigaro classification. This itself can be used as a mnemonic for classifying the etiology of chronic pancreatitis. In etiology is nothing but cause. So what are the causes? You can rule it out as, you can list it out as Tigaro. One is toxic, that is metabolic. Whatever we said, alcohol or smoking, all this will lead to accumulation of certain products. This is metabolic. Other than that, we can't identify what is the proper cause. Hence, it is called as idiopathic. Other than that, genetic causes, then autoimmune, then recurrent severe causes, and obstructive causes. Basically, we can list the causes under these main headings. ಆಯಿತಾ? This is just to remember. ಇದನ್ನು ಒಂದು ಕ್ಲಾಸಿಫಿಕೇಶನ್ ಸಿಸ್ಟಮ್ ಅವ್ರು ಮಾಡಿದ್ದಾರೆ, ಅವ್ರು ಕೊಟ್ಟಿದ್ದಾರೆ. ಆಯಿತಾ? If you want, you can remember. You can just remember the classification name, Tigaro. Okay. After this, clinical features. Just like I have explained before, the patient can present with diabetes mellitus because of endocrine insufficiency. And usually, whenever we see the pancreas of a chronic pancreatitis patient, there will be calcification. ಯಾಕೆ I have explained the saponification process during pathophysiology of acute pancreatitis. Like whatever the digestive enzymes of the pancreas is released, if the duct is obstructed, that will lead to digestion of the pancreas itself. Okay, so ಇಲ್ಲಿ ಏನೇನು enzymes obstruct ಆಗುತ್ತೆ, this will start digesting pancreas, and it will also start digesting greater omentum, which is made up of fat. This fat is broken down into fatty acid and glycerol, and these fatty acids, whichever are there, they will go and bind with calcium, leading to calcification, that is leading to deposits of chalky white deposits. ಇದನ್ನು explain ಮಾಡಿದ್ದೆ ನಾನು. So these chalky white deposits are nothing but calcifications. So usually whenever we scan the patient, we will be having pancreatic calcification. Usually in 30 to 40% of cases we will see this. Other than that, just like I have explained, there will be impaired digestion of fat leading to steatorrhea. Okay, so other than that, there will be chronic pain, and hence that will be the most common symptom of the patient, that is abdominal pain. Okay, so how will we diagnose this? Same like acute pancreatitis, we'll go for MRCP, which is only diagnostic, but gold standard investigation is ERCP, that is both diagnostic as well as therapeutic. Okay, so what will we see on ERCP? It will show alternate stricture and dilatation of the pancreatic duct. Basically, there will be dilatation and there will be stricture. There will be dilatation, there will be stricture. Itara. This will be like a Rudrakshi Sara anta heltivana, bead on string appearance, or string of pearls. Heng bekare helbodu, string of pearls or chains of lakes appearance. Basically, beads, then a thread, beads and a thread. Itara appearance irutte, because this part will get dilated because of accumulation of pancreas, and this will be having fibrosis. Stricture ಇರೋದು ಫೈಬ್ರೋಸ್ ಆಗಿದೆ, ಬೇರೆದು ಅಕ್ಯುಮುಲೇಟ್ ಆಗಿದೆ, ಈ ಥರ. ಓಕೆ, ದ್ಯಾಟ್ ವಿಲ್ ಬಿ ದ ಅಪಿಯರೆನ್ಸ್ ಆನ್ ERCP. ಆ್ಯಂಡ್ ವಾಟ್ ವಿಲ್ ಬಿ ಯೂಶಲಿ ದ ಕಾಂಪೋಸಿಷನ್ ಆಫ್ ದ ಸ್ಟೋನ್ ಇಫ್ ದೇ ಆರ್ ದೇರ್ ಅಂದರೆ ಕ್ಯಾಲ್ಸಿಯಂ ಕಾರ್ಬೋನೇಟ್, ಬಿಕಾಸ್ ಕ್ಯಾಲ್ಸಿಯಂ ಜೊತೆಗೆ ಫ್ಯಾಟಿ ಆಸಿಡ್ ಬೈಂಡ್ ಆಗಿದೆ. ದ್ಯಾಟ್ ವಿಲ್ ಬಿ ಜಸ್ಟ್ ಲೈಕ್ ಚಾಕ್. ನಾವೇನು ಚಾಕ್ ಪೀಸ್ ಯೂಸ್ ಮಾಡ್ತೀವಿ, ದಟ್ ಈಸ್ ಕ್ಯಾಲ್ಸಿಯಂ ಕಾರ್ಬೋನೇಟ್, ಸೇಮ್ ಲೈಮ್ ಸ್ಟೋನ್ ಥರ ಇರುತ್ತದೆ. ಓಕೆ, ಇಫ್ ವಿ ಗೋ ಫಾರ್ ಎಂಡೋಸ್ಕೋಪಿಕ್ ಅಲ್ಟ್ರಾಸೌಂಡ್, it will be the most accurate investigation for diagnosis of minimal change. Okay, and there is a criteria called Rosemont criteria, which is based on this endoscopic ultrasound. So ಇದರಲ್ಲಿ ಏನು ಹೇಳ್ತಾರೆ ಅದೆಲ್ಲ ಇಟ್ಸ್ ನಾಟ್ ನೀಡೆಡ್. ಬೇಸಿಕಲಿ ವಿಲ್ ಕ್ಲಾಸಿಫೈ ದ ಎನಿ ಡಿಸೀಸ್ ಫಾರ್ ದ ಈಸ್ ಆಫ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್. ಇದು ಸಿವಿಯರಾ ಮೈಲ್ಡಾ ಹೆಂಗೆ ನಾವು ಅಲ್ಲಿ ಕ್ರೈಟೀರಿಯಾ ಯೂಸ್ ಮಾಡ್ತಿದ್ವಿ, ಅದೇ ಥರ ರೋಸ್ಮಾಂಟ್ ಕ್ರೈಟೀರಿಯಾ ಅಂತ ಒಂದಿದೆ, ಅದನ್ನು ಯೂಸ್ ಮಾಡಿ ದೇ ವಿಲ್ ಕ್ಲಾಸಿಫೈ ಕ್ರಾನಿಕ್ ಪ್ಯಾಂಕ್ರೈಟೈಟಿಸ್ ಅಂತ ಗೊತ್ತಿರಲಿ. ಓಕೆ, so this was what I was saying. So if there are multiple deposits or calcifications, that will be appearing as beaded appearance in case of ERCP, and on CT scan you can see numerous calcifications in the pancreas, chalky white deposits ide. Okay, after this X-ray ಅಲ್ಲಿ ಏನೋ ಕಾಣ್ತಾ ಇದೆಯಾ, there is blackening shadows. Okay, then chains of flake appearance, basically this. Okay, so this is how we diagnose chronic pancreatitis. What will be the management? So management ಗೂ exocrine insufficiency ಇದೆ, endocrine insufficiency ಇದೆ, pain ಇದೆ, ಮೂರನ್ನು ಮ್ಯಾನೇಜ್ ಮಾಡಬೇಕು ನಾವು. ಸೊ exocrine insufficiency, how will we manage? We'll give enteric coated pancreatic enzyme supplementation. Basically exocrine insufficiency ಇದ್ದರೆ there is some problem with the duct ಅಂತ. Just like I said, exocrine ಅಂದರೆ duct, endocrine ಅಂದರೆ hormones. So if there is these stones which are obstructing the duct, these enzymes are not reaching the intestine. That is the main purpose. ಇದು ಅಬ್ಸ್ಟ್ರಾಕ್ಟ್ ಆಗಲಿ ಬಿಡಲಿ, ಎಂಜೈಮ್ ರೀಚ್ ಆಗ್ತಿಲ್ಲ, ಅದು ಈ ಅಬ್ಸ್ಟ್ರಕ್ಷನಿಂದ ಆಗ್ತಿರೋ ಪ್ರಾಬ್ಲಮ್ ಏನು, ಎಂಜೈಮ್ಸ್ ಆರ್ ನಾಟ್ ರೀಚಿಂಗ್. ಸೊ ಇಫ್ ವಿ ಕ್ಯಾನ್ ಗಿವ್ ದೀಸ್ ಎಂಜೈಮ್ಸ್ ಆಸ್ ಅ ಸಪ್ಲಿಮೆಂಟ್ ಥ್ರೂ ಓರಲಿ, ಆಯಿತಾ, ದ ಪ್ರಾಬ್ಲಮ್ ಇಸ್ ಸಾಲ್ವ್ಡ್. ಸೊ ಇನ್ ಆರ್ಡರ್ ಟು ಟ್ರೀಟ್ ದ exocrine insufficiency, we are giving certain enzyme supplementation which are synthetically prepared and they are enteric coated, which will serve the purpose of pancreas. Okay, endocrine insufficiency ಏನು, endocrine ಏನಾಯಿತು, 90% of islet cells are damaged. Islet cells were secreting insulin, so we will give it externally. So insulin ಆಚೆಯಿಂದ ಕೊಟ್ಟರೆ ಇಟ್ ಇಸ್ ಪರ್ಪಸ್ ಇಸ್ ಸರ್ವ್ಡ್, ಇನ್ಸುಲಿನ್ ಅಷ್ಟೇ. ದೆನ್ ಕ್ರಾನಿಕ್ ಪೇಯ್ನ್ ಇದೆ, ಪೇಯ್ನಿಗೆ ಏನು ಮಾಡ್ತೀವಿ, ಅನಾಲ್ಜೆಸಿಕ್ಸ್. ಸೇಮ್ ಲೈಕ್ ಇನ್ ಅಕ್ಯೂಟ್ ಪ್ಯಾಂಕ್ರೆಟೈಟಿಸ್ ವಿ ವರ್ ಗಿವಿಂಗ್ ಮೆಟಾಮಿಝೋಲ್ ಆ್ಯಂಡ್ ಬುಪ್ರನಾಫಿನ್, ವಿಲ್ ಗಿವ್ ದ ಸೇಮ್. If the pain is still not relieved on giving opioids also, then we'll go for endoscopic, that is ERCP stenting and oblique stone removal. If there is a stone visible, we'll remove it. If it is not, if there is only obstruction, we'll remove the we will relieve the obstruction by putting a stent. Even if the pain still persists, then we'll go for cilian ganglion block, because this is a nerve which is carrying the pain sensation from pancreas. So if we block this nerve by giving anesthetic, then pain will be relieved. Even if after doing all this, if the pain is not relieved, then we'll go for surgery, that is removal of pancreas or whatever is possible, which I will be listing below. Okay, so this is the management. Basically we are managing exocrine, endocrine as well as pain. Okay, what are the surgeries we'll do for chronic pancreatitis? There are two types of procedures mainly: drainage procedure, resection procedure. Resection basically means removal of part of pancreas. Drainage means there will be certain obstruction, we will be removing it and we will be draining the pancreatic juice. Okay, that is Pusto's procedure. It is also called as longitudinal pancreatico-jejunostomy. Everything will be in the name itself, we just need to understand the name. Okay, what we will be doing? Longitudinally connecting the pancreas and jejunum, that's it. Okay, so opening the pancreatic duct and suture it with jejunum. They have shown the procedure here. What we are doing, we have opened the pancreas, right? Longitudinally we have opened the pancreas and we are connecting it with the jejunum. So ಇಲ್ಲಿ ಏನು ಓಪನ್ ಮಾಡಿದಾಗ ಏನು ಕಾಣಿಸ್ತಿದೆ, we are able to see stones. So we will remove these stones which are leading to basically obstruction. ಸೊ ಅದನ್ನು ರಿಮೂವ್ ಮಾಡಿ ಏನು ಮಾಡ್ತೀವಿ, ಸೀದಾ ಜೆಜುನಮ್ಗೆ. ಯಾಕೆ ಜೆಜುನಮ್ಗೆ ಕನೆಕ್ಟ್ ಮಾಡ್ತೀವಿ? ಡುಯೋಡೆನಮ್ is already it is small and it is enclosing the pancreas, so there is no use of connecting it to the pancreas again. However, jejunum has most number of loops also, so it's easy to connect it to jejunum. Okay, so connect it to jejunum. So this is longitudinal pancreatico-jejunostomy, which is done as a drainage procedure in case of chronic pancreatitis. In case of resection, there are two procedures: Bejer's procedure and Frey's procedure. Okay, Bejer's procedure or Bejer's procedure ಅಲ್ಲಿ ಏನು ಮಾಡ್ತಾರೆ, this is also called as duodenal preserving pancreatic head resection. ಎಲ್ಲ ನೇಮಲ್ಲೇ ಇದೆ. Duodenum is preserved. Okay, pancreas head ಏನಿತ್ತು, that pancreas head is resected or removed. Okay, after this what they'll do, they'll suture the body, whichever the part of the pancreas is remaining, that will be sutured with jejunum. ಓಕೆನಾ? ಸೊ ಇಲ್ಲಿ ಹೆಡ್ಗೆ ಮತ್ತು ಡುಯೋಡೆನಮ್ಗೆ ಏನು ಕನೆಕ್ಷನ್ ಇತ್ತು ಅದು ಹೋಯ್ತು. ಫಸ್ಟು ವಿ ಆರ್ ಪ್ರಿಸರ್ವಿಂಗ್ ದ ಡುಯೋಡೆನಮ್ ಆ್ಯಂಡ್ ರಿಮೂವಿಂಗ್ ದ ಹೆಡ್. ಸೊ ದರ್ ಇಸ್ ಓನ್ಲಿ ಬಾಡಿ ಲೆಫ್ಟ್ ನೌ. ಓಕೆ, ಸೊ ದರ್ ಇಸ್ ಓನ್ಲಿ ಬಾಡಿ ಲೆಫ್ಟ್ ನೌ. ಆಯಿತಾ? ಇಷ್ಟು ರಿಮೂವ್ ಮಾಡಿದ್ದೀವಿ. So this body, whatever is left, the duodenum, this continuation part will be jejunum. So this body will be sutured with, jejunum will be sutured with the body of the pancreas. Ishte, simple. So this part is empty now. Okay, so this procedure is Bejer's procedure. Similarly, in Frey's procedure, what we'll do, we'll go for local resection of pancreatic head with longitudinal pancreatic jejunostomy. So similar to that, we'll go for local resection of the pancreatic head and then join it with jejunum. ಓಕೆ, ಇಲ್ಲಿಗೂ ಏನು ಡಿಫ್ರೆನ್ಸು, ಡಿಯೋಡನಮ್ ಪ್ರಿಸರ್ವ್ ಆಗಿತ್ತು, ಇಲ್ಲಿ ಡಿಯೋಡನಮ್ ಪ್ರಿಸರ್ವ್ ಆಗಿಲ್ಲ ಅಷ್ಟೇ. ಓಕೆ, ಸೊ ದೀಸ್ ಟು ಆರ್ ದ ಪ್ರೊಸೀಜರ್ಸ್. ಇಫ್ ದ ಪೇನ್ ಈಸ್ ನಾಟ್ ರಿಲೀವ್ಡ್ ಈವನ್ ಆಫ್ಟರ್ ಪೇನ್ ಮೆಡಿಕೇಶನ್ಸ್, we have to go for surgical management, and the surgical management is through these procedures. Okay, this comes to end of chronic pancreatitis. Okay, then starting with carcinoma of the pancreas. Okay, so carcinoma of pancreas, it is the most common genetic mutation in carcinoma pancreas or cholangiocarcinoma, that is gallbladder carcinoma, is KRAS or P16. ಇವೆಲ್ಲ ಜೀನ್ಸ್ ಬೇಕಾಗಿಲ್ಲ. ಓಕೆ, ಸೊ ರಿಸ್ಕ್ ಫ್ಯಾಕ್ಟರ್ಸ್ ಏನು ಕಾರ್ಸಿನೋಮಾ ಆಫ್ ಪ್ಯಾಂಕ್ರಿಯಾಸ್ಗೆ? What is the risk factors? There are established risk factors and there are certain associations which might cause carcinoma of pancreas. Established ಇದು ಬಂದು ಸ್ಮೋಕಿಂಗ್, ಹೆರಿಡಿಟರಿ ಫ್ಯಾಕ್ಟರ್ಸ್ ಆರ್ ಜೆನೆಟಿಕ್ ಸಸೆಪ್ಟಿಬಿಲಿಟಿ, ಲೈಕ್ ಹೆರಿಡಿಟರಿ ಪ್ಯಾಂಕ್ರೆಟೈಟಿಸ್, ಮನೇಲಿ ಯಾರಿಗಾದ್ರೂ ಅಪ್ಪಂಗಿತ್ತಂದ್ರೆ ಮಗಂಗೆ ಬರೋದು ಅಥವಾ ಅಮ್ಮಂಗಿತ್ತಂದ್ರೆ ಮಗಂಗೆ ಬರೋದು, ಇದು ಕಾಮನ್. ಅದರ್ ದನ್ ದಟ್ HNPCC which is autosomal dominant. Other than that, hereditary breast and ovarian cancers. If there is any family history, then there can be, since these all are autosomal dominant, it will usually, if the parent is suffering from this, child will suffer from this anta. Whereas ataxia telangiectasia, which is autosomal recessive, there can be a skip generation. ತಾತಂಗಿದ್ದು ಆಮೇಲೆ ಮೊಮ್ಮಗಂಗೆ ಬರ್ಬೋದು ಆ ಥರ. ಓಕೆ, ಸ್ಕಿಪ್ ಜನರೇಷನ್ ಇರುತ್ತೆ ಯೂಶಲಿ. ಅದರ್ ದನ್ ದಟ್, ಫೆಮಿಲಿಯಲ್ ಏಟಿಪಿಕಲ್ ಮಲ್ಟಿಪಲ್ ಮೋಲ್ ಮೈಲೋಮಾ, which is again autosomal dominant, and Peutz-Jeghers syndrome, which is again autosomal dominant. We'll speak about this. Okay, it is a maximum risk factor, Peutz-Jeghers. ಇದರಲ್ಲಿ ಏನಾಗುತ್ತೆ, I will be telling you later. Okay, other than that, what are the associations? If the patient is having diabetes, if the patient is obese, and if he is having chronic pancreatitis and is not treated, then it can go for carcinoma of pancreatitis. Okay, so what is the most common type of pancreatic cancer? It is adenocarcinoma, that is arising from the gland, and the non-specific is carcinoma embryonic antigen, whereas specific tumor marker is CA19-9. If we are able to detect this in blood, then it is confirmed that he is having CA pancreas. If these levels are raised, then it is specific. Whereas if CEA is raised, there can be a possibility that it can be a CA pancreas, but it is not specific to pancreas alone. There can be other cancers also where CEA is raised. That is the meaning of non-specific. Okay, what is the chemotherapy regimen we will give for CA pancreas is gemcitabine, and usually whatever the metastasis happens to liver most commonly. Aita? So most common site of CA pancreas is head usually, and then body, and then tail. Basically ಈ ಕಡೆಯಿಂದ ಈ ಕಡೆಗೆ ಕ್ಯಾನ್ಸರ್. Pathology, it is associated with intense desmoplastic reaction, and there is increased fibrosis around the tumor. Okay, so what will be the clinical features in case of a patient suffering from carcinoma of pancreas? Most common symptom will be jaundice usually. Other than that, any cancer will have usually weight loss. So first jaundice irutte, adadmele weight loss irutte. So if there is head of the pancreas is involved in cancer, then jaundice will be more prominent, whereas in case of body and tail of the pancreas, weight loss will be more prominent. So based on this also we can guess, okay, where is the cancer, if it is there in head or if it is there in tail and body. Okay, 1 second, I'm getting a call, 1 second.